Hello everyone, this is Dr. Sadia Shah, one of the mentors at Study FCPS, which is a part of Study Medic group. This is the platform um, dedicated for the students who are applying for fellowship in obstetrics and gynecology. So FCPS stands for Fellowship of College of Physicians and Surgeons, and it is one of the most prestigious institute of Pakistan. And getting the degree from the mentors uh, at the FCPS convocation is one of the big day, and I shall pray that everyone who is uh, training in obstetrics and gynecology should see that one day. And study FCPS is one of the platform with the aim to facilitate the students with the updated guidelines and the format so they can appear in the exam. And it aims to help the students in their studies, and it is an online platform with all the courses for the FCPS written exam also, and FCPS extended talks also. Also, it has the courses for IMM students who are applying for the IMM, that stands for the intermediate module, both theory and um, talks group. So we have recently started this YouTube series only for to facilitate the students, and this um, summary and this presentation today is in that is continuing with that format, and we hope that this will be beneficial for you. Our aim is three P's. That is, you have to prepare, you have to perform, and you have to practice. Because practice makes a person perfect. So uh, one of the this is one of the steps that we have taken. So it could also make the students uh, can revise, so that the students can revise the GTD in a very short time, as the GTGs are very long, and sometimes the students get confused or overwhelmed that how we should read the guidelines, how we should make the summaries, and it's very lengthy. So it is a small initiative from my side and from my team, Study FCPS, so we can guide you through it. So let's begin. So intrahepatic cholecystitis in pregnancy comes under the domain of maternal medicine, which is a very important domain, and no any question or no any paper is incomplete without any question from maternal medicine. So green top guideline RCOG has recently updated, not recently, but 2 years has updated this guideline. Previously, it was known as the obstetric cholestasis, and now it is known as intrahepatic cholestasis in pregnancy. The name has been changed. So, I will walk you through this guideline summary, and we will discuss through our path the important points that could help you solve MCQs, BCQs during your exams, and could clear your concepts. Okay, so first of all, we will start with the prevalence. So, what is the prevalence? The prevalence of intrahepatic cholecystitis is influenced by genetic and environmental aspects, and it varies between the population. In United Kingdom, because these guidelines are from the United Kingdom, intrahepatic cholecystitis in pregnancy affects 0.7% of the pregnancies, and 1.2 to 1.5 percent of the women of Indian, Asian, or Pakistani Asian origin. Intrahepatic cholecystitis of pregnancy (ICP) is a multifactorial condition, and around 25% of the pregnant women, if complain of itching during their pregnancy, the majority of these does not have and do not develop intrahepatic cholecystitis of pregnancy during the 9-month period. So this is one of the very important BCQs that used to come in the exam. That how many percent of the patients or pregnant women complain um, uh, about itching, but they are not diagnosed as a case of intrahepatic cholecystitis. So the answer would be 25%. Or you can select the option near to this percentage if this option is not present. Thank you. Coming to the clinical aspect, how the patients can present. Intrahepatic cholecystitis in pregnancy is characterized by pruritus, that is itching in the absence of primary skin condition, with abnormal maternal bile acid concentration. The patients usually complain of itching on the palms and the soles that is severe during the night, so it interferes with the sleep. The onset of the symptoms is most commonly seen in the patients during the third trimester. However, it can appear early in the pregnancy. The diagnosis of intrahepatic cholecystitis of pregnancy should be considered in a pregnant woman who have itching in the skin of normal appearance, which means it should not be associated with any rash. And clinically, there should be raised bile acid concentration of approximately 19 micromole per liter or even more. Now, normally the bile acids can increase in the pregnancy, but the upper limit is to be kept in mind. The upper limit of normal bile acid concentration during the pregnancy is 18 micromole per liter. Above that, there is a clinical condition called gestational pruritus. So, what is the classification? The classification is that itching along with the peak bile acid concentration of 19 micromole per liter, then the patient is diagnosed as a case of gestational pruritus. However, if the range is between 19 to 39 micromole per liter, we will characterize that woman as a mild case of intrahepatic cholecystitis during the pregnancy. Moderate intrahepatic cholecystitis of pregnancy, these patients also present with a complaint of itching, and the raised bile acid concentration ranges between 40 to 99 micromole per liter. However, in the cases of severe intrahepatic cholecystitis of pregnancy, the concentration increases up to 100 or even more than that. So, dear students, you have to remember each and every range of the classification of the intrahepatic cholecystitis, because these are the favorite BCQs by College of Physicians, Surgeons in Pakistan, and also by the Royal College of Obstetrics and Gynecology. Because in the anxiety and in the stress of the exam, we tend to forget or we tend to confuse the limits, the ranges of a mild, moderate, and severe intrahepatic cholecystitis of pregnancy. So please um, remember it thoroughly. And sometimes, because 19 is more similar, like 9 is more similar to 6, so sometimes they twist it with 16 micromole per liter, so you have to remember and memorize the exact values of these conditions. Okay, I will repeat it again. If the normally upper limit of bile acid concentration during the pregnancy is 18 micromole per liter, if it is 19, it is termed as gestational pruritus. And if this concentration ranges between 19 to 39, and so it will be called as mild intrahepatic cholecystitis in pregnancy. And if it is between 40 to 99 micromole per liter, the patient is diagnosed as a case of moderate intrahepatic cholecystitis of pregnancy. And last but not the least, if the patient has the serum bile acid concentration of more than 100 micromole per liter, it is regarded as severe intrahepatic cholecystitis in pregnancy. Okay, so what could be the differential diagnosis? Every patient that comes in with the pruritus is not always intrahepatic cholecystitis or pregnancy. You have to keep in mind the other diagnosis also. So, the new onset pruritus in pregnant women is associated with itching unlikely to be intrahepatic cholecystitis of pregnancy. If the itchy skin looks abnormal, that is other than the excoriations, there is a rash, there is a redness, there is scar, so you have to consider other causes, and for that, to evaluate the causes, you have to go through the liver function test and bile acids test, but they are not required routinely. In pregnant women with persistent itching and normal appearance of the skin and normal blood test, the initial diagnosis is to be gestational pruritus, that is to be considered. Women can go on to develop intrahepatic cholecystitis of pregnancy up to 15 weeks even after a diagnosis of gestational pruritus. This means that if the patient has been diagnosed with a case of gestational pruritus, they are at a high risk to develop intrahepatic cholecystitis of pregnancy. What could be the risk of fetus due to this clinical condition? We have to counsel the patient antenatally. We have to advise the woman with moderate or severe intrahepatic cholecystitis of pregnancy that they are at an increased chance of developing meconium stand amniotic fluid during the labor and the birth. Advise women with moderate or severe intrahepatic cholecystitis of pregnancy that their baby is more likely to receive the neonatal care. So, when managing such patients, we have to keep in mind that these patients need multidisciplinary care. So if a patient comes or diagnosed as a case of intrahepatic cholestasis of pregnancy, you have to take the neonatologist on board. Additional laboratory or imaging investigations are not recommended unless itching is associated with atypical clinical symptoms, the presence of relevant comorbidities, or in early onset severe intrahepatic cholecystitis. I hope I'm clear so far. Moving on, consider additional postnatal investigation in women whom resolution of the abnormal liver function test is delayed or does not occur, which means even after 4 weeks of the delivery, the patient's symptoms are not being resolved or patient liver function tests are not being resolved or they are deteriorating. Consider discussing the care of the woman with severe or very early or an atypical presentation of what appears to be an intrahepatic cholecystitis in conjunction with hepatologist. Confirm the diagnosis of intrahepatic cholecystitis of pregnancy in the postnatal period at least 4 weeks after the birth with resolution of itching and liver function test returning to the normal. That includes bile acids also. So we have to counsel the patient, reassure the patient that this condition that you have developed during the pregnancy is not a lifelong condition. After the delivery, more likely the symptoms are going to resolve on its own. And for that, for the confirmation, we are going to repeat the bile acids after 4 weeks of the birth of the baby in the postpartum. We also have to advise the woman that with isolated intrahepatic cholecystitis of pregnancy and a singleton pregnancy, the risk of stillbirth increases above population rate once the serum concentration is 100 micromole per liter or more. That means in severe, the risk is high. In mild intrahepatic cholecystitis of pregnancy, in women with bile acid concentration of 19 to 39 micromole per liter and no other risk factors, advise them that the risk of stillbirth is similar to that of the background risk. And in the patients with mild intrahepatic cholecystitis of pregnancy, we consider for the planned birth by gestational age of 40 weeks. That could be both by normal vaginal delivery or cesarean section, that it would be individualized. Moderate intrahepatic cholecystitis of pregnancy in women with the peak bile acids concentration of 40 to 99 micromole per liter and no any other risk factors, we have to advise them that known risk of stillbirth is similar to background risk until the gestational age of 38 to 39 weeks. We consider planned birth at the gestational age of 38 to 39 weeks in such patients. However, in severe intrahepatic cholecystitis of pregnancy, the woman with peak bile acid concentration of 100 micromole per liter or more, we advise them that the risk of stillbirth in such patients, in such mothers, is higher than that of the background risk. So this is a flow chart explaining what we have just read, what we have just studied, what we have just discussed. This chart is from the guideline, and this summarizes whole the points that we have discussed up till now. If the patient, pregnant woman, comes to you with the itching, you have to first of all, after history, and you have to examine the patient and examine the skin. Examination is very important. Particularly, you have to ask the patient where does she feel the itching more at what time, and what is the texture of the skin. If the skin appears normal or does the skin appears abnormal. If the skin appears abnormal, then it is not intrahepatic cholecystitis of pregnancy, and then you have to consider other diagnosis in the clinical context. It could be any skin disease, it could be because of any other liver disorder. But if the skin appears normal or there are only scratch marks, because some patients they tend to have long nails, and because of this, or they have dry skin, so because of that they have the scratch marks because of the severe itching, we have to go for the blood test that would include bile acids and liver function test. And now on the basis of the values, we will then classify that in which category does our patient lie. So if the concentration, sorry, if the bile acid concentration is less than 19 micromole per liter, that would be gestational pruritus. Okay, so we will retest if ongoing itching, bile acids may increase, and women may develop intrahepatic cholecystitis of pregnancy. So we have to counsel the patients. We also have to counsel the patient that in the gestational pruritus, there is no any effect on the stillbirth. There is no any impact on the preterm birth, and there is no any impact on the birth timing as per the evidence, as per the literature. However, if bile acid concentration tends to fall between the range of 19 to 39 micromole per liter, or if it tends to fall in 40 or more than 40, then we have to go step by step, that is history examination. Structural history is to be taken and examination is to be done to consider the other causes and diagnosis. In history, we will ask the patient that since when she is having the itching, what is the severity of the itching, what is the timing of the itching, and does any else in the family has any itching problem or not, does she has any skin disorder or not, has she felt this problem during the previous pregnancies if she is multigravida. Also, we have to ask the patient that recently has she changed any her detergent, any her clothes, any soap that she uses or what, because obviously allergens could cause this itching also. So we have to take the structured history. And also we have to ask the patient regarding how is her perception for the fetal movements. And then we have to examine the patient thoroughly, particularly regarding the skin, regarding the areas where she complained about itching. Additional liver investigations are not routinely indicated, but they can be considered if atypical features occur. If the bile acid concentration ranges between 1939 micromole per liter, our diagnosis is going to be mild intrahepatic cholecystitis of pregnancy. So how we are going to manage? We will retest and clinically indicated if ongoing itching. Bile acids may increase and the woman may develop moderate to severe intrahepatic cholecystitis of pregnancy, so we have to counsel the patient. No effect on stillbirth and 16% of the preterm birth rate. However, we consider the planned birth by 40 weeks. Now, these two are the BCQs that do appear in your exam. That what is the risk of preterm birth if the patient has diagnosed case of mild ICP, or they tend to give you the serum bile acid concentration and then they ask what is the preterm birth rate. So it is approximately 16%. But if the patient comes to lie in the category of moderate or severe, then we have to review the patient clinically and we have to repeat the bile acids concentrations to assess the trajectory. That is, means that either they are rising or they are at the plateau or they are declining. If the bile acid concentration ranges between 40 to 99 micromole per liter, we will categorize the patient as moderate intrahepatic cholecystitis of the pregnancy. And we have to counsel the patient also the risk of stillbirth, which would be similar to the general population, and 19% of preterm birth rate is there. We also counsel the patient that considered planned birth will be there by 38 to 39 weeks. This was all about gestation pruritus, mild and moderate. Now we come to the severe intrahepatic cholecystitis of pregnancy, and the stillbirth rate is high, and by the general population by 35 to 36 weeks. 30% risk is for the preterm birth rate, and planned birth is considered by 35 to 36 weeks of gestation, however, under the cover of antenatal corticosteroids. What will happen if we have a twin pregnancy? Intrahepatic cholecystitis of pregnancy and the twin pregnancy. In such cases, we advise the woman with intrahepatic cholecystitis of pregnancy and twin pregnancy that the risk of stillbirth is higher in comparison with a twin pregnancy without intrahepatic cholecystitis of pregnancy. We also have to counsel the patient, and clinicians should be aware that CTG, that is cardiotopography or fetal ultrasound, do not prevent the stillbirth in cases of intrahepatic cholecystitis of pregnancy. We also advise the woman with intrahepatic cholecystitis of pregnancy that the presence of risk factors or comorbidities such as gestational diabetes or preeclampsia or multifetal pregnancy appear to increase the risk of stillbirth and may influence decision making around the timing of planned birth. Antenatally, we have to advise the woman with intrahepatic cholecystitis of pregnancy that there are no any treatments that improve the pregnancy outcome or raise bile acid concentration. Treatment to improve maternal itching are of limited benefit. However, calamine lotion can help. We do not routinely offer ursodeoxycholic acid for the purpose of reducing adverse perinatal outcomes in women with intrahepatic cholecystitis of pregnancy, as there is no any evidence in the literature or in the guideline. So this is the summary of what we have learned up till now. If the patient's bile acid concentration lies less than 19, She is termed as pruritus gravidarum. We have to take the proper history, and this chart with the weekly follow-up of how frequently we have to go for the bile acids is very important. It is almost 1 to 2 weekly, but in cases of severe, it could be individualized. The stillbirth rate is also given, which can be asked during the BCQs, that in case of mild, it is 0.13%, it is unchanged. In moderate, it is 0.28%, and in severe, it is raised. So these percentages are to be kept in mind. Consider topical emollients such as aqueous cream with or without the methanol to ameliorate, that is to relieve the patient's skin symptoms. Consider maternal vitamin K treatment only if there appears to reduce the absorption of dietary fats. Advise women that intrathecal cystitis of pregnancy in itself does not impact their choice and mode of birth, and that these decisions should be based on usual obstetric practice for that woman. This means mode of delivery is to be decided or is to be individualized by the obstetrician according to the patient. If there is no any contraindication to the normal genital delivery, which means if there is a breech present, if there is no any scar, if there is no any previa, if there is no antepartum hemorrhage, if there is no any maternal emergencies, the patients can be opt for normal genital delivery. Offer continuous electronic fetal monitoring to women with severe intrathecal cystitis of pregnancy. There is insufficient evidence for or against continuous electronic fetal monitoring in women with peak bile acids below 100 micromole per liter, which means in mild and moderate there is no any evidence. However, a shared decision can be made based on the comorbidities and the preference. Intrapartum advise the woman that the presence of the risk factors like gestational diabetes mellitus, preeclampsia, multifetal pregnancy appears to increase the risk of adverse perinatal outcomes, and that these conditions themselves may necessitate monitoring during the birth or in conjunction with intrathecal cystitis of pregnancy may influence decision making around and monitoring in the labor. Advise women that meconium stain liquor is more common in moderate and severe intrathecal cystitis of pregnancy, and that this will influence decision making around continuous electronic fetal monitoring. Offer women with uncomplicated intrahepatic cystitis of pregnancy standard analgesia and anesthesia options for the birth, and there is no any contraindication for any, and it depends upon the anesthesia, so you have to take the anesthetist on board. Advise women that there is no any evidence of an increased risk of postpartum hemorrhage if they have uncomplicated intrahepatic cystitis of pregnancy. For women who have uncomplicated intrahepatic cystitis of pregnancy, follow-up should be arranged at least 4 weeks after the birth to confirm the resolution of intrahepatic cystitis of pregnancy. And this is one of the favorite questions of both College of Physicians of Pakistan and RCOG. Advise women that they should anticipate itching and raises maternal bile acid concentration to resolve after birth. What contraception can be offered? Advise women that intrathecal cystitis of pregnancy itself does not influence their choices of contraception or hormone replacement therapy. However, for the women with intrathecal cystitis of pregnancy and previous cholestasis secondary to the combined hormonal contraception that would include estrogen containing, advise them to switch or to use progesterone only contraception or non-hormonal methods. In women with previous intrahepatic cystitis of pregnancy requesting hormone replacement therapy, consider offering if there are no any other contraindications to use. According to the medical eligibility criteria, that is according to the UK MEC, the contraceptive choices for intrahepatic cystitis of pregnancy includes copper-bearing intrauterine devices, levonorgestrel releasing system, Mirena, progesterone-only implants such as Implanon, Nexaplanon, Jadel, progesterone-only injectables, and progesterone-only pill can be used without any restrictions, and they come under the category 1, that is UK MEC category 1. However, combined hormonal contraceptions can be used in a woman with intrahepatic cystitis of pregnancy provided. Okay, so there's a condition you have to keep in mind, provided that they do not also have a history of contraception related cholecystitis. Now, these patients are very concerned that what will happen in the next pregnancy, particularly the primary gravida. So you have to advise them or you have to counsel them that intrahepatic cystitis of pregnancy is a recurrent condition and it could appear in the subsequent pregnancies, the recurrence is high. So how we can assess this patient? So at the time of the booking, we have to perform a baseline liver function test and a bile acid concentrations with booking blood investigations. That include complete blood count, blood group of the patient, urine, detailed report of the patient, also viral screening regarding hepatitis B surface antigen, anti-HCV, and in Pakistan also HIV. According in addition to these booking investigations, if a patient comes with a previous history of intrauterine status of pregnancy, then baseline liver function test and baseline concentration is to be done and is to be documented in their notes. Thank you so very much. Coming to the question, I have added one question just for the brainstorming. Which one of the following is not a known complication of intrauterine status of pregnancy? Just pause the video for a few moments and then think, and then move to the next slide for your answer. Okay, so let's begin. And the answer to this question is neonatal jaundice. Intrauterine cystitis of pregnancy is a clinical condition that is characterized by pruritus and altered liver function test. The common abnormality seen is elevated serum bile acids, but derangement in other markers of liver function tests like transamin, bilirubin, and GGT can also occur. This was all from my side. This was all from my team. Thank you so very much for listening. Thank you so very much for joining. And we request you to support us. So support us and subscribe to our channel. And so we should also get recognition. And please give us the feedback. Please comment so we can know which topics you are interested. So we can also add those in our schedule, in our syllabus, and in our series. This series is known as triple P, which means you have to practice, you have to perform. Only with the practice can a student be perfect, and they can successfully go through all the exams. These are the international and national courses that are offered by Study Medic, and FCPS is one of its branch, which is specializes in FCPS courses of obstetrics and gynecology, both intermediate module and FCPS. So this was all from my side, and thank you so very much. Please subscribe our channel so you can get the notifications, and also leave the comment for the topics that you are interested in. Thank you so very much. Dr. Sadia Shah, FCPS Gynecology and Obstetrician, signing off. Thank you.